We'd like to welcome you to the Healthcare Revolution podcast, where we empower you to take control of your health, restore your trust in the medical system, and achieve lasting wellness. I am your host, Brad Powell, Doctor of Physical Therapy and owner of an award-winning foundation physical therapy here in the Salt Lake Valley. Each episode, we dive into all things rehab prevention, overall health, bringing you expert insights from leaders across the healthcare fields. Please note, while we aim to provide with the best knowledge and advice, the opinions shared represent those of experts in the field and are not to be replaced with professional medical advice. So let's revolutionize healthcare and wellness together. Welcome to the Healthcare Revolution podcast. We're so excited today to talk about building sustainable careers in healthcare, specifically in physical therapy. That is kind of our specialty here. And we're going to talk about all the things that are leading people to not have sustainable careers. There's more physical therapists leaving the profession right now than there ever has been. And it's also the best career that there is out there, according to many sources. And, every year physical therapy payment, what we're paid, goes down, but inflation goes up. And what I mean is insurance companies are paying us less and less every year, but inflation keeps going up. And it's getting to the point, it's really challenging to be sustainable. So there are more healthcare professionals, like I said, leaving the profession. This is not just PT, it's healthcare in general. And we want to talk about what's happening and why it's important for the public to understand this. But we want to make this very positive. There's so many good things coming. We just need to shift. There's some shifts that need to happen in healthcare to make it more sustainable. And I have an absolute expert guest who is going to give us a lot of good insights into this. So a few other things I want to address before I introduce him. So one of the greatest untapped opportunities in healthcare isn't new technology or intervention, but it's better collaboration between professionals. It's utilizing each other to leverage to be able to improve the patient experience and make our careers more sustainable. So physical therapy is uniquely positioned to lead the future of healthcare. I'm going to take that one to my grave. We really are centered so well to help prevent so many conditions, whether it be heart-related, lung conditions, musculoskeletal. We are positioned extremely well to prevent so many of those things, and we can help more. There's so much we can do on the front lines, and I'm super excited to talk about that. Today's conversation is about building that future, about the future of healthcare, making it more accessible, making it better, improving our systems so that way our healthcare workers are thriving, we're thriving, and we're all working at this together. So we're pulling the curtain back, and we're talking about the real work behind legislative matters, what changes on a state level, and the efforts that it takes to make things happen. And I'm so excited to introduce our guest, Dr. Drew Wilcox. So excited to have him on. He is just a breath of fresh air to work with. This guy will go to bat for healthcare, and specifically for PTAs, for physical therapists, for our profession. He has served on the APTA Utah chapter board for over 12 years now, and just keeps signing up. I don't know why he keeps signing up to serve more, but he just keeps showing up, and he gives his whole heart. He drives all the way from St. George to Salt Lake City to come up on the hill. He's here in the podcast in Harriman, Utah, and just so excited to have him. He is a clinical educator, program director. He's an advocate. He's committed to strengthening the profession through leadership and collaboration. So long story short, Drew, welcome to the podcast.
It's good to be here.
It's so good to have you on. It's been long overdue, and just so much appreciation for what you do for our profession. I don't think we highlight people enough, and I really hope that this podcast is highlighting you and the work that you've done. And I know you're going to turn it right back and say, I hope this is about our profession and making our profession better, because that's who you are. But I'm super excited to talk about this today.
Well, I agree. It is about the profession and improving healthcare overall. And I like that you talk about how PT is positioned where it is, because I don't think there's a better profession to change the delivery of healthcare.
Yeah,
that's
absolutely.
The revolution. We're looking long term with everything we do. We're not looking at let's get 2 hours of relief. So I couldn't agree more. PT is in a position to really blow up the healthcare system and improve everything we do.
Yeah, we're going to dive super deep into this. Tell us what got you into physical therapy profession in the beginning. What was the journey?
Initially, I grew up playing a lot of ball, a lot of sports. There wasn't, I played everything, wrestled, basketball at the same time, and I played a lot of baseball. I grew up in Taylorsville, and Taylorsville baseball was everything back then. And so I played a lot of baseball, a lot of shoulder injuries, football. And so I had a lot of injuries growing up. And so I was in PT all the time. And it actually initially put me into athletic training. I graduated high school in 95, and in the 90s, nobody was going into PT. We were struggling back then. And so I had some friends that were physicians that said, you look at athletic training. And so I started there and then moved over and found the PTA program at Salt Lake Community College. Athletic training was fun, but it just didn't challenge me to the point that I felt comfortable every day. I wanted a little bit more education. So I found the PTA program at Salt Lake Community College, and I jumped on that and went through it and went on to get other degrees. I got a bachelor's at Weber State and then a master's through LSU and then a PhD down at Rocky Mountain in Provo. And it's just kind of been a driving force that extra challenge. I always need that next challenge. And so that led me from athletic training to physical therapy. And this is where I've stayed.
Yeah. What I love about you, Drew, is most of your age group, this is not saying that you're old.
The gray hair gives it away.
Most of your age group is not that way, right? Like most of your age group is, let's just stay where we are. I don't want progress. I don't want to have to be pushed. I don't want to go to the next level. I don't want to, we talked about having labs, like being able to order labs as a physical therapist. That was kind of a big push legislatively this year because of the Office of Professional Licensing's recommendations. They went and did a lot of work and study and reviewed our profession and recommended to the legislation that we need to change this so PTs can order labs. But we know that it was kind of shut down by one of the senators calling a PT and said, I don't know why I would ever order that, right?
Yeah.
And that's kind of what your age group is kind of notorious for, is like, let's not move on. Right. But I love that you are progressive. You're like, what's the next thing? How can we make this better rather than stopping it here? Right.
Well, and and that's the thing. And I've had multiple mentors in my career, and they've all been that same mindset that if you're not pushing yourself, if you're not progressing, you're regressing. If you're willing to be stagnant, everybody else is passing you up, which means you're just regressing. You're going back. We talk about with my students all the time, the half-life of information now is 5 years. In 5 years, half of everything you know is outdated. So if you're not pushing yourself and learning more and going through continuing education and getting more certifications or degrees, where are you going to be in 10 years? Because those PTs, physicians,
most people
nurses,
are practicing for 25, 30 years.
Yeah.
Like how outdated are you? Are you up on the research? Are you up on what the new clinical models are?
Yeah.
Right. And practices out in the community, they're 20 years outdated.
Right.
Tell us about some of those.
It's amazing to me. I remember at Salt Lake Community College, Ken Freeman, one of my favorite people, was lecturing us on pain science, especially chronic pain. And he was talking about all the variables that go into this, that pain science is not an anatomical abnormality. It's not you stub your toe, you break your toe, and it causes pain. There's a literal anatomical problem that's causing the pain. And he was talking about how your mood, your sleep, all of these things go into chronic pain. It's an interpretation of an impulse on a nerve, and there's a lot of variables that go into it. 15 years after graduation, I was with him at Combined Sections meeting, and we went to a lecture, the Maley lecture, on that exact thing. And I got to sit with Ken. It was awesome. And I leaned over to him and I said, you taught us this 15 years ago. Is this still not common sense? And he just kind of laughed. He said, it takes about 20 years for it to make it to the clinic, which amazes me because to me, as soon as you learn something, you want to implement it immediately. But there's that old saying, you can't teach an old dog new tricks. Once we're settled and we're stagnant, we don't want to change things.
How do you foresee that being an issue for the public?
it's an internal issue, but it's also a public issue. They need to be able to trust the therapist. I mean, we're seen as leaders as soon as a patient comes in to see us. That's the view that they have, is we're seen as leaders, we're seen as knowledgeable, we're licensed practitioners. And that's something that we need to own. If we're willing to stay up on the research, that changes our practice. We're not doing things from 20 years ago. I knew a PT a long time ago who every patient got ultrasound. Doesn't matter if it's an elbow, a shoulder, a hip, ultrasound every patient. And luckily that was 20 years ago, and you don't see that very often anymore. We've changed how we practice. We've modernized things. Ultrasound is a nice tool and does a good job for temporary pain relief, some deep heat, but the long-term outcomes don't show any difference.
Yeah. And the biggest issue that we see in the PT profession, especially the 20-year ago PT, which you still see some clinics practicing today, is that everyone got the same treatment.
Yes.
Right? It wasn't that ultrasound is bad or ultrasound's not effective. It's that as you came, I mean, I've spent my whole life in PT. And, I'm 35 years old, but I spent a good 10 years, 30 injuries in the PT clinic, so I spent a lot of time. The model was you came in, you got ultrasound. That was the first thing. Yeah. You got the aide would just get the ultrasound gel and just wave the wand over the injury, warm it up, get the heat. Then we do a heat pack and electrical stim. So you'd have the ultrasound for 10 minutes. You have the heat and electrical stim for 10 minutes. And then the aide would massage you. And so you're 35, 40 minutes in before even talking to the physical therapist. You talk to the physical therapist for 5 minutes, and then you work with an aide for another 20 minutes on some exercises, and then you go home, right? That was the old way.
Right.
Right? The biggest issue that I see with it is that it was not customized.
Right.
Like everyone got the exact same treatment. And yeah, you could say 5 minutes of that was customized, and maybe the exercises were a little bit more customized. But there's no customization there. Like everyone just got the same blanket treatment. And that's where it became problematic, because it was just everyone was in and out, and it was getting the same thing, right? Do you see any other issues for the public on kind of that model?
I think there are on that older model, there are a lot of issues because we weren't thinking long-term outcomes necessarily. We're thinking short-term. We want, and I think
people feeling better.
Yeah. We want
it
people
feels
to
good.
leave. Exactly. We want people to leave feeling good. And ultrasound does a good job of that because it's a good deep heat. But when we look at long-term outcomes and the actual healing, ultrasound's great if it leads to an active exercise routine.
Exactly.
Or some manual therapy where we can actually make long-term benefits.
Mm-hmm.
And I have no problem with ultrasound or e-stim. I love them. I use them in the clinic, but I'm not going to use ultrasound to heat somebody up if I can get them on the treadmill or on a bike to warm up that way.
Yeah.
More long-term benefits. And so I think, from a public perspective, those are the questions you want to ask. In fact, the APTA came out 10 years ago, 15 years ago with a document. It was called the Choosing Wisely campaign, that if your therapist is using modalities, passive modalities like ultrasound and e-stim consistently without active exercise, you need to ask them why. Even the APTA came out and said just passive modalities are not considered physical therapy.
Yeah.
And that old model, we did a lot of that.
Yeah.
And I think the new model, what the public sees now is we're doing a lot more with manual therapy, hands-on, and a lot more aggressive therapeutic exercise, even HIIT training in clinics.
Mm-hmm.
Some good friends of mine in St. George, they're doing acute neuro rehab. They're doing HIIT training with brain injuries.
What is HIIT training for those that don't know?
So HIIT training is high intensity interval training. And it is what you would see in the gym with big time athletes. And they're using it, of course, it's adjusted for these patients, but they're using high intensity training for people with spinal cord injuries and brain injuries and strokes. And the outcomes are amazing.
Yeah.
And of course, it's adjusted down to the tolerance of the patient, but the long-term benefits.
Yeah.
And now we know the science behind it and what the chemistry of the body that's released with high-intensity training actually improves the healing process and speeds that up. So there's tons of benefits. And I think that's what we have to look at from a public perception is, are we really giving the public what they're asking for? Or are we giving them the quick hit 2 hours of relief, and then they need to come back for another one tomorrow?
Yeah.
Are we educating the public? I mean, how many times do you go into the physician and actually learn about what you're dealing with and how to deal with it on your own?
Yeah.
And, I started teaching in 2010. And that's one of the biggest things we emphasize with our students is you need to be educating patients consistently. Every time they come in, you need to be educating them. What they're dealing with, how they can deal with it on their own. In the future, if it comes back, how do they deal with it without having to come back to us?
Yeah.
There's so much education that can take place. And we look at therapeutic exercise. We spend how many hours and hours learning how to do it, but really just a few pieces of advice to patients can make a big difference for them.
Absolutely. We've talked a lot on this podcast about not outsourcing your health to someone else, that you need to take ownership. You need to be in the driver's seat. And the driver's seat comes with education. It comes with knowledge. It comes with learning. It comes with having great healthcare providers that help you actually take things into your life so you can take the driving wheel, right? That you can be in the driver's seat, that you're no longer in the passenger seat or in the back seat and someone else is taking over your body and your health and telling you what you should do at every corner. You do the research, right? You get the advice, you get get resources and experts in your life that you trust that can help you, but ultimately you are the person that is in the driver's seat at all times.
Yeah. And I think that's a big thing to get across to the public is they have to take ownership of their own healthcare. If they're passive, they're going to do whatever. It just doesn't work. If you're passive with your own healthcare, somebody else is making your health decisions, your life decisions for you.
Yeah.
Nobody outside of healthcare would ever give that ownership to somebody else.
Yeah.
But for some reason, it's been acceptable in healthcare. And when patients own their own health, they spend less money on healthcare. They're more aggressive with how they take control of their life in other areas. There's so many benefits. They just have to realize their healthcare is their own. Even though they're going to professionals who are knowledgeable and licensed, there's still multiple options for anything they're facing.
Absolutely.
So own it and find out what your options are and which one's best for you, not which one's best for the clinic.
Yeah. And I love what you're saying here. Like we just kind of full picture. You're talking about like clinicians, if they're not staying on top of the research, they're going to be outdated. You're talking about how every healthcare provider is there's a certain bias there, right? Whether it be a surgeon's most likely going to talk to you about surgery, right?
Yeah.
PT's most likely going to talk to you about PT. We're all essentially biased in our own areas, but sometimes you need multiple opinions, right? To get a really broad perspective on how everyone thinks about that particular injury. And sometimes you're just lacking a little bit of information to get out of the spot you're in. And by having that little bit of education, it's not groundbreaking. It's like, oh my gosh, that information is what I needed to get out of the slump that I'm in.
Yeah.
Right. And it wasn't just like, I need a good 20 exercises. It's like, no, tweak these two things and you're dialed, Yeah.
It can be as simple as, somebody comes in with low back pain and a repeat client. Well, how much are you walking and what's your gait pattern look like? Sometimes it can just be as simple as getting out and walking and increasing that to where you're walking 1 or 2 miles a day, getting that rotation in the lumbar spine, getting the compression forces adjusted. Sometimes it's just that simple. Let's just walk more. Let's move more. And that doesn't take a lot of education.
Yeah. I'm going to be real vulnerable here. 2 days ago, I was squatting and I was getting a 3-rep max and I was lifting as heavy as I've ever lifted. And I came home and I couldn't stand up my back. I was so embarrassed. I love treating back pain. It is my bread and butter. It's what I love treating. And I'm just like, I couldn't even stand up. I'm like, I'm embarrassed, right? Like, and I knew I'd pushed too hard and I kept going and I shouldn't have done it, right? I know better. And in the PT world, we call it extension bias or extension obstruction. And like, I couldn't stand up straight and it was just killing me. I'm 2 days into this now. And because of what I know, I was able to get out of that ridiculously fast, right? And I went and worked out this morning, went on a run. Like, little tweaks in your life will make a drastic difference. I've seen people have my injury that I had 2 days ago and spend years in it. But because of what I know, I'm able to expedite that, get blood flow to it, because a lot of people are afraid to move it, right? I'm like, I'm bending, I'm moving, I'm doing pelvic tilts, I'm getting the spine blood flow, I'm walking. I'm not just sitting on the couch just waiting for things to come to me. I'm actually implementing what I teach patients every day, and it gets me out of that inflammatory response ridiculously fast.
Yeah. And we're lucky because we've had our careers and our education, so we understand that side of it. The nice thing nowadays, you can go to ChatGPT and talk and just put in the prompt of what you did to hurt your back, how old you are. I mean, you can put in as much information as you want, but how do I recover from this? And it'll come up with some ideas for treatment. It's not hard to research those ideas and see if they're appropriate. There's so much information out there. I mean, I'm a geek. I'm a research geek. I could read research all day long.
PhD.
It is, and that's what pushed me to my PhD. I wanted more information.
Yeah.
But Google Scholar is the first thing that opens up when I open up the internet every day.
Yeah.
I open up a browser, it goes, Google Scholar is my homepage because there's so much information there.
Yeah.
And
don't you love it now? I mean, when you got your PhD, the level of effort that you guys put in to reading research articles, I mean, we can capture information in about 5 minutes that took you guys 3 days.
Oh, absolutely.
Right? Like the PhDs nowadays, I'm sure, are so different breed than PhDs back then. Like,
it's so different. I have my students do a literature review their final didactic semester. So final semester, we have them in class. They do a literature review. They do the old way using the database, online database search, which now that's the old way.
That's great.
But we also use AI as a companion, and then they have to merge it. We can take AI and do a literature review that used to take a couple days, 20 to 30 hours, and 5 minutes, and that lit review is done. Now, there's still some issues. You still have to verify that the actual research articles are legitimate.
Yeah.
But majority of them are nowadays. In the past 2-3 years, it's changed dramatically.
And you got to know how to prompt it, right?
Yeah, like prompting is a skill.
The specificity of prompting is really important because you're looking at certain research, certain types of research, whether it be a randomized control trial or a systematic review, like maybe a number of people in the study or who owned the study, who's the sponsor of the study, right? You get to get real specific on what you want, but you're saying with high specificity, it's ridiculously accurate.
Yeah, 5 minutes and you'll get a great review. And the more information you have on how to read research, and a lot of people, I think there are a lot of people in the public with graduate degrees that have gone through research and they understand how to read that. And now we're adding AI into things. It's just changing the ballgame. It's amazing to me that the old way of doing research is using a digital database through a university. That's old.
Yeah, it really is. Absolutely.
So there's so much information out there. There's like you mentioned, the prompting with AI is a skill. You can learn how to do that and you improve it all the time. In fact, ask when you input your information into the AI platform, ask it how to improve the prompt. It'll tell you where your gaps are.
That's awesome.
So there's so much areas.
I want to jump back real quick.
Yeah.
Because I don't want to miss this opportunity to talk about this. We talked about clinics now having different tools, right? You'll go in clinics and you'll see barbells, you'll see squat racks, right? You'll see heavier weights, big kettlebells. Before we just using TheraBands and small, pastel colored dumbbells, right? That was all we used.
Right.
And now we're doing HIIT training. We're having squat racks. We're doing heavier lifting, teaching deadlifts, right? But we also have seen this little pendulum switch in our profession where we've gone so heavy to passive modalities, meaning the passive, comfortable, getting people feeling good and not progressing towards things that are going to create long-term results. But I mean, I met with a panel of PhD people that were running a new program for physical therapy clinics. They wanted me to be on their advisory board on clinical internships for students. And every single one of them were bashing passive modalities and said, we will not even teach that in our curriculum.
Interesting.
And I just observed, I was just curious, right? And I'm young. I'm all about the loading. I'm all about, you see in my clinics, we got barbells, we got heavy weights, right? This pendulum shifts where it's like all or nothing, right? And, I don't want to get to the point where we're not using the feel-good stuff.
Right.
But we got to know when to use the tools. Give us your thoughts on that.
I think that's the key, is knowing when to use them. Passive modalities are a great tool to use when needed. If you can't get a lot of therapeutic exercise because of a lack of range of motion or too much pain, something like that, where you can't move well enough, passive modalities can help us get to that therapeutic exercise, those exercises and stretches that'll give us long-term benefits. So if you need to do that, great. And I still teach them in my program. It's one of the classes I teach. Modalities have their place. I do think we used to use them too much. If a patient can warm up on a treadmill or on a bike, why aren't we doing that and getting the benefits of the exercise versus the minimal benefits we get from a heat pack and e-stim?
Yeah.
There are benefits to e-stim. It does improve circulation. We have benefits. There's benefits there, but there's more benefits to working up a sweat.
Mm-hmm.
So I think, hopefully, and I do think that as a profession, we're moving that direction. There are a lot of people against passive modalities. I know a lot of therapists that aren't using them at all. And for their practice, if that works, that's fine. For me, I think they still have a place. I still think that they're valuable to get patients to the point where we don't need them anymore. And once we're to that point where we don't need to use an external heat source to heat somebody up for exercise, if they can get there on the bike or on the treadmill, then that's where we go.
Yeah, absolutely.
My goal, and I teach this to my students all the time, the goal should be that the day after treatment, the patient knows they were in physical therapy. They feel that delayed onset muscle soreness. Shouldn't be dramatic. It should go away within a few hours, but they should feel it the next morning.
Yeah. And us setting that expectation too, right? Because potentially the older generation knows the old model of PT, right?
Yeah.
And perhaps we need to spend some time educating on the new model of PT, right? This new PT, it's going to be different, right? Have you been to PT before? I think that's a question all of us should be asking. You know, whether you are a nurse, whether you're a physician, you need to understand where people are starting. And asking that question, like, have you been to a clinic like this before? Do you know how this works? Do you know how this surgery works? Do you know how this PT works? Let me explain the process and the roadmap of where we're going to go. The first PT appointment, you might be a little sore.
Yeah.
Like, our goal is to diagnose this properly, and I'm going to be pushing and prodding a lot of things to figure out the diagnosis, and then we're going to challenge you a little bit, and we might have some muscle soreness. But the goal is not to increase your pain; it's to decrease your pain and get your muscles working to where we can create a change, right? But I love that. And, our profession is notorious for shifting this pendulum so far. But I think we all need to come to the conclusion that just know when to use the tool, right? If you got this toolbox of all this, this nice fancy toolbox with all these drawers, are you going to use the same screwdrivers every time, or are you going to use a different tool, right? Match the tool with what you need, right? Don't say that's a bad tool, because it's not a bad tool. Right? It's just, you got to know when to use it.
Yeah. And I think that's a great analogy, because if you're going to use a flathead screwdriver for a Phillips head screw, it'll probably work. You can figure it out.
Yeah.
But you could grab a Phillips head screwdriver and make it a lot easier.
Yeah, absolutely. Like, and sometimes the right size of Phillips too, right? Or the right size of a flathead really is meaningful, because you can do the job so much better.
Yeah.
Right? And I really want to comment on this as well. Like, what would you give someone you loved? If they're in your clinic and they were in a ton of pain, would you load them up on a barbell day one? You'd probably give them some feel-good stuff and get them training, right? Get the blood flow. Like, you're not just going to start hammering it day one. Like, you're gonna have some time easing into it, get people like pain down, get it more stable, and then start loading them up. But we can't wait till the 10th visit to start loading them up, right? Like, you can do things at the same time simultaneously.
Right. And that's exactly right. And that's why I think modalities have their place. We just need to know when to stop using them. Mm-hmm. It's a tool that works and works really well to get us to an active exercise regimen. Yep. And once we can get to that active exercise, that's where the long-term benefits are.
Absolutely.
I'm a big fan of modalities, but I do think they've been overused for a long time. And that's for the public. I think that's one of the things they need to understand, that e-stim, heat, massage, they're nice. They feel great. But if you're not doing active exercise, you're not getting any long-term benefits. Mm-hmm. And that's really where every physical therapist that I have ever known, PT, PTA, the active exercise is where we just geek out. Mm-hmm. That's what, we get a cancellation. What do you end up doing in the clinic? If you've got 20, 30 minutes, chances are you're trying out a new exercise, or you're bouncing ideas off the other therapists, coming up with different ways to treat patients.
Yeah. And we're talking about this customized treatment for patients.
Exactly.
Why can patients not just Google a bunch of exercise for back pain or any other type of pain?
Yeah. And it gets kind of scary.
Why does specificity matter?
Yeah. Everybody's different. The funny thing is, if you look at an anatomy book, it gives you one base anatomical structure for the body. Yet if you really look at everybody you work with over the years, everybody has a little bit there's a little difference in everybody's anatomy. Nobody looks the same. Nobody's the same height, the same weight, the same build. There's a little difference in every anatomy. There are muscles that are listed in anatomy books that don't exist in certain parts of the population. They just don't have them. And so we look at, when we were talking about AI earlier, AI is going to give you the generic routine, but without getting some education, how do you know what's going to work for you? Mm-hmm. And that's where the knowledge part comes in with this. That's why, to me, patients always view therapists as leaders, because the knowledge side that we can give them.
Yeah.
Here's some options for you. This is probably going to be the best one. And then let the patient choose which one they like the most.
Yeah.
The downside to that is you're always going to get patients that come into an outpatient clinic. Oh, I don't have a lot of time. So today I think I just want the e-stim and the massage.
Just to feel good stuff.
Yeah.
Give me a couple of days of relief.
Yeah.
It's true.
But really, if we can be specific with patients with those exercises, and I love it when patients come in with ideas on their own. Mm-hmm. I think it's great. Let's have the talk.
Especially when they say, you ask them, what makes it feel better when I do this movement?
Yeah.
Oh, okay. That is really helpful, right? I mean, two things come to mind as you talk about that. Number one, when we did human dissection in PT school, I think we had 10 bodies. And what I realized, it was just like this huge light bulb moment for me, that we studied different bodies because everyone was so different.
Right.
And we are just as different inside as we are outside.
Yeah.
Right. And when you just Google a bunch of movement patterns or exercises, and you're in a very particular type of pain for your body type, your age, all the things you got going on in your life, some of those exercises may hurt you and some may help you, right? But finding out which ones and where you got to tailor, it's not saying that certain exercises are bad, because all exercise is good, right? But when you're in pain, picking the right treatment is really important, right? And my other example is I just bought a bunch of jackets for all my front office coordinators. I realized the jackets, they're all the same jacket, but are all my front office coordinators the same?
Yeah.
Right?
Fit is
Poor
different.
Whitney up here, she's got a short torso, so the jacket on her is super long. And then you have someone with a longer torso, which the jacket is a little too short on her, right? So I ended up finding a perfect jacket for Whitney. She's wearing it right now, so you have to comment when you walk out. But she has a really short torso, and I figured out this is her jacket. So I went and bought her one and got it embroidered and said, Whitney, I need you to try this on. And it fit her perfect. And I was so stoked. But I mean, that's just a simple analogy to explain, like, all of our bodies are so different. And we can't just get one jacket to fit everyone, or glasses, right? Like, we're all unique, and we need to uniquely customize treatment to what people actually need.
That's a great analogy, actually, because I mean, how many times do you just go buy something off the rack and it fits you great, and your buddy has the same thing and it doesn't fit him at all? I mean, it's a normal thing. Not every exercise is going to work for every patient. Not every treatment is going to work for every patient. And that's why I mentioned, earlier with the AI stuff, if patients will educate themselves, but you still have to see somebody that has that knowledge and that understands that, because one of the things I love about teaching is, as students are going through and trying different techniques out on each other. Now, they're healthy students in a class, so they're all young and healthy. So they don't have any injuries typically. They don't have the comorbidities, all these other things going on that play into it. But they can't use the same technique or the same grip on everybody in the class, because you'll have a girl that's 5'2" and 120 pounds. And right now I've got a guy that's 6'4" and weighs about 270. The same thing isn't going to work for those two. You have to adjust.
With it being a teacher, being a professor, you got to adapt the way you teach.
And we have to, adapt how we teach, and we have to teach the students.
I've never actually thought about that.
Adapt. Every treatment, they have to adapt to that patient, because, I've got big hands. So when I'm doing some joint mobilizations, let's say, I could treat most patients fairly easily because I can control what I need to control very easily.
Yeah, big hands, a lot of grip strength, right?
Yeah.
You got certain techniques that work really well for you, but you get this smaller gal with small hands and maybe not as strong grip strength. You're teaching her the same technique. It's not going to work for her.
Can't do it. She has to adjust for her
and you're just like,
anatomy.
Get stronger grip strength, right? Just try harder.
That's me.
It's not going to work, right?
I'm just Mick in the corner, just hollering.
I love it. Let's get to the meat of this conversation. So we're talking about building sustainable like just improving healthcare. Like, what do you see in the future of healthcare in general? Like, what do you hope to see?
So I've been a tenured professor now for a while. I've been in academia. When we talk about healthcare, that I go automatically to education because that's where I see us with the ability to make some drastic changes to improve the healthcare system. To be a PT, it is a doctorate degree. It has been for a long time. That's nothing special. There's also PTAs, a physical therapist assistant, who are licensed to practice physical therapy. PTAs focus on the interventions. They focus on the actual treatments, where PTs get the treatments, but they also get the extra knowledge and education on evaluation skills. So PTAs, it's a 2-year program. For DPTs, it's a 3-year program. There's an extra year in there. They have a little bit more clinical education where they're actually doing internships, and then they go deeper into evaluation skills. And the old model, these are 2 separate silos. In fact, for a PTA to go get a DPT, there's so many barriers in place that it rarely happens. You do see it happening, but it's rare. And so you see PTAs just staying in their lane and then PTs over here. And they've always been considered separate. But when we look at the cost of healthcare, if we could cut the cost of healthcare education, it changes the ballgame. So if we took PTA programs, which are undergraduate, and then created a bridge directly to PT, we took a 3-year doctorate down to maybe a 2-year doctorate with 2 more years in undergraduate. That's 4 years of PT-specific education, more than the doctors of physical therapy are getting right now. But we've also taken some of that and put in undergrad, which is a lot cheaper cost. We've just changed the ballgame because we've taken the cost of education down so much that it creates space for doing fellowships, residencies, more internships where they can add specialty knowledge onto it. And then when they come out, the salaries aren't so overwhelming.
Yeah.
We don't have to expect massive salaries to make up for the massive debt if we adjust how we educate.
And just give some perspective to what Drew's talking about here is most of my classmates graduated with over $200,000 in debt. The starting salary for a PT when I graduated 7 years ago was $72,000. You do the math there and you tell me how long it's going to take to pay off that loan, right? And it's just exponentially gone up since I've graduated, right? And back when I looked at the research when I was in school, the research said if you graduate with over $150,000 in debt, as a physical therapist, you'll never pay it off in your lifetime. It just won't, the math doesn't math. Right? And it's only going up, right? So I love that what you're thinking about the future is let's shift it into a different model, but give them more education, more specialty, more time, right? Because one of the biggest barriers to all of this is tuition.
Exactly.
Like this bill came out. I forgot what the bill is calling. It's pretty much saying these professions are professional and these are not. Give us some insight into that bill.
Yeah. So this is coming from the federal government, and they're basically coming out and they're attacking the cost of education is really what it comes down to. And the cost of physical therapy education has dramatically increased year after year for a long time. And so what they've come out and said that they're no longer going to classify the doctorate of physical therapy as a professional degree. And what that means is it cuts down the amount of government-backed student loans that PT students can have. And I think it drops it from $200,000 down to $100,000. You can't do that with PT education. You can't get your doctorate in PT education for that cost when you consider you have to have a bachelor's degree first.
So this bill wasn't necessarily about picking on professions, saying you're not professional and you're professional. It was about the economics of it.
I really think it was. I don't see it as attacking the profession because we're making strides politically in physical therapy across the country and from the federal standpoint. I don't see it as attacking physical therapy as a profession. I think it's attacking the cost of physical therapy. One of the things that isn't really publicized, it's not out there much, but the U.S. Department of Education does not recognize the DPT as the necessary degree for physical therapy. So our accreditor, CAPTE, the Commission on Accreditation in Physical Therapy Education, has to write a self-study every year to the U.S. Department of Education explaining why we have the doctorate degree. The USDE sees it as degree creep and not necessary. They don't understand the extra things that have been put into the profession, all the extra knowledge that's added into the profession over the past 20 years that really required that move. I have a faculty that works for me who's a DPT, and she's amazing. And one of the things that she talks about is PTAs today are doing what PTs did 20 years ago. Mm-hmm. The roles have changed that much.
Yeah.
And which means the PTs of today are doing things that have never been done in physical therapy before.
Yeah,
the progression of the profession is dramatic. There's all these factors feeding into it, but really what's happening is the U.S. Department of Education is saying your cost of education versus the salaries after are not matching up. Your cost is rising too fast. There's got to be a lid on it somewhere, so we're gonna be that lid.
What are you hoping the change is made based on that bill with universities?
If it doesn't go through as a professional degree, if PT is not recognized as a professional degree, it's going to be catastrophic. A cheap DPT program is $100,000.
Mm-hmm. Minimum.
Yeah. That's just the tuition cost. You're looking at $100,000.
So essentially, we're capping at what they can lend, right? What they can get from the government to get to the minimum. Right. But how else are they going to pay for tuition? Right. So there's got to be other ways. And the government's saying, yeah, you can take out other loans. We'll give you pathways for that. But, what I hope to see in the next decade is that we figure out things what you were saying. How can we shift part of the degree down to a more cost-effective way where people aren't graduating with $200,000 in debt? We're graduating with $100,000 in debt, right?
Right.
And obviously it's going to be very catastrophic at first because a lot of people are going to be like, I'm not going to that profession because I can't physically get the loan to be able to support that, right?
Right.
And I don't know how many options there are and what needs to pivot there, but is there anything else you hope to see happen if that does pass?
If you mean if it is recognized?
Yeah.
Well, I would like to see us change this model no matter what. If it passes, I think the traditional DPT model stays. But my hope is that this is some motivation to change. Instead of having a PTA silo and a PT silo, we create a highway similar to the nursing model where there's multiple entry points and exit points, multiple on-ramps onto the highway, multiple exits where you can start as a PTA with an associate degree and you can be licensed and start practicing with a certain scope of practice.
And then you can just keep going up.
And have a different scope of practice, and then go get your doctorate and have a different scope of practice.
By having multiple of these, how does this create sustainability for the physical therapy profession?
I think, one of the benefits of having PTs and PTAs and different scope for each is you get two minds working on every problem now. Mm-hmm. We're getting two educated minds with two different points of view looking at each problem. So, some cases, some injuries, they're pretty straightforward and simple. A lot of them aren't. If we're assessing gait pattern, I look at specific things. I worked with a buddy of mine for years, and we'd assess gait pattern. And he's looking at something completely different every time. And the funnest thing when we do that is bringing that together and saying, okay, now which part of this needs to be corrected first?
Yeah.
What's creating the biggest problem? So we're getting two different points of view looking at each problem. Then you can bring in other healthcare professionals too, whether it's a PA, a nurse practitioner, a physician. We've got technology now. You can record the gait pattern with the phone. Just send a text over to the physician. Hey, this is what we're seeing today. Here's some of the issues we want to correct, and then have the physician give some feedback on it. So we can use
more
technology.
Collaborative approach.
Absolutely.
Because a lot of people think like, well, I want continuity of care. I want to talk to the same person every time. And sure, there's value in that. But having multiple eyes on an injury, because injuries can be so complex, you almost need different perspectives to solve it in an efficient way.
And I worked with a couple of physicians in St. George who specialized in back pain. Neither one of them were surgeons. It was a couple of brothers. And I still talk to one of them. But they were on the fourth floor or third floor of the building, and our PT clinic was in the basement. And they used to come down to the basement to see their patients. Yeah. They didn't make their patients reschedule and go upstairs. They wanted to see how their patients were doing in therapy.
Just walk down, yeah.
And so they'd come down and just spend a couple minutes just to see how their patients were moving in therapy. And we would have that collaboration and point things out, and we'd come to an agreement, and the patient's there in the conversation too.
Yeah.
And it made for me as the therapist, it was a blast. I loved it because that collaboration, that teamwork really is motivating to me.
Yeah.
For the patients, I think they respected that physician a lot more, knowing the physician's not making them pay another copay, schedule a different visit. We'd come together as a team and I'll talk about it.
I love that. We're going to kind of shift gears here and talk about what legislative changes, in summary, are happening right now that are leading to the sustainability. And then also, we're going to kind of pull the curtains back and talk about what happens behind the scenes to make these legislative changes happen. You laugh because there's a lot. There's a lot people don't know.
Yeah, and it seems to be in a good way. I'm saying this in a good way. There's more every year. It used
really
to be very, every few years we'd have a bill that we'd worry about.
Yeah.
But now it's fairly consistent, which is a really good thing because we're making long-term changes at the local level. And there's the old adage, politics are local. And we're starting to do that, especially in Utah. We're noticing that and we're attacking it that way. We're reaching out to local senators, local representatives. We're going to the state level and making changes there that nobody else in the country has been able to do. Having PT as primary care, that's a game changer for physical therapy. All the studies point to lower cost of healthcare using physical therapy. So why did it take us so long to get there? Well, I think we were waiting on the federal government to do something.
Yeah.
That takes way too long. So it's been kind of fun. So some of the bills you mentioned, or you were asking about this year, one of them is the Office of Professional Licensing Review that's just reviewed the Practice Act and is kind of clarifying some things, which I think it's great. It was a good process. The other bill, to me, that's the bigger bill is the Fair Copay bill. And that's basically saying physical therapy is primary care, yet copays can be as high as $90 a visit. And if you go see a physician, you're not paying $90 a visit. So they're still treating it as a specialty, even though it's not.
Yeah, and then PT, you're going to multiple visits. Most time to a physician, you're going once, right? So $90 for 12 visits, that can hike up pretty quick for people.
Yeah. And it really becomes an access to care issue. When you're paying $90 a visit or $50 a visit or $40 a visit, but you're having to go to 6, 8, 12 visits, it's, for a lot of people, it's just not possible. Yeah. So it really blocks their care. It blocks them from getting care.
Yeah.
And so then they have to go to the physician, and that's where they end up getting more imaging done. They end up medications. And I mean, that's why we had the opioid crisis. I absolutely believe that was a problem mostly due to high copays, because insurance will pay for that opioid 100%, or maybe you might pay $5.
And PT, I got to put in time and I got to put in a lot of money.
Yeah. And so if you're having to pay $90 a visit for PT, but $5 for a pill.
And keep in mind, the PTs are probably only getting $80 of that anyways.
Yeah.
Right? Like,
yeah.
The PTs are getting just the chump change, and with a high copay. So what we're saying is we're changing legislatively the structure of this to support what it's supposed to support, prevention, right? Like, let's get the most cost-effective options first and not have a lot of high cost to it, right? It should be that way, right?
Yeah, we need to limit the cost, and we need to improve care. I mean, especially in rural areas, and most of Utah is still rural. And if you're in...
Limit the cost and improve care. I love that.
It's, if you're driving 45 minutes to go see a PT, plus you got to spend $90 each visit. I mean, it really is inhibitory.
Yeah.
So if we can cut that $90 down to being a normal $20 copay, now things are a little bit easier to manage.
Yeah.
And
tell us about the level of effort that it takes to pass one of these things. Give us, if PTs are listening to this, or just healthcare, or just the public in general, what does it take to actually make this happen?
Yeah, this is the side that most people don't see. Two things you never want to see made: sausage and laws. And I make my own sausage, so I've seen that side of it, and I think it's prettier. There's a lot that goes into it that I've had to learn over the years, and I've luckily had mentors that I could reach out to, and it's worked. We're kind of standing on others' shoulders when we do this, because Utah's had direct access for, I think 25 years. Yeah, I mean, it's been a long time. But we never really had direct access because it was still controlled by the gatekeepers and the insurance companies.
Yeah.
So over the years, I've learned a lot about how to get this through. And it's a lot of handshakes. It's a lot of small, just, handshakes and face-to-face communications up on the Hill. You're standing outside of the sessions and hoping somebody walks by that's has some input on the bill that you're working on. It's a lot of emails and phone calls, and we've got that text thread going that you're on that could be nothing for a day, then all of a sudden it blows up, and we got an emergency
60
happening.
text messages that we got to respond to.
The bill's going tomorrow, and we've got to get people.
What
there.
I love that everyone that's on that message is super intelligent people that can quickly figure out solutions. And we all know people. It's like, who knows this person? Who can reach out to them?
Yeah.
Right? Because the biggest thing is these senators, these legislators, they don't know the information that they need to make good decisions. So we get smart people to go educate them. They're open to this most of the time, right? And they just need information. But if no one in our world is able to educate them or willing to, they're not going to create a change. Right. So it's a lot of these logistics of who to reach out to, who to make connections with, who to teach, who to educate. But essentially, all of it is education. If these legislators are appropriately educated, there's a good chance they might make a good decision. Right.
Right. I absolutely agree. And I think especially at the local level, we have that opportunity. It's really hard. I've advocated for physical therapy for bills federally. I've gone to DC and I've been up on the Hill and I've tried to meet with senators and representatives there. It's very hard to do that.
Yeah.
They're
on a national level.
On the national level. Yeah. Their schedules are such that, it's almost impossible. And most of the time you're meeting with staffers, you never get to see them.
Yeah.
That's not the case locally.
Yeah.
I've met with every one of my Southern Utah representatives in the past few years. I've gotten to be friends with a couple of them. I can just send a text to them real quick and easy. They're good people who really are trying to help. Politicians get a bad name.
Oh, man. Senator Vickers, I love that man. He's such a good dude.
He has done so much for the state. And when you meet him and talk to him, he's just the guy next door.
Yep.
And he really is. And that's one of the things I love about him. Walt Brooks, I'll throw that name out because he's another one. He's from St. George. His family goes back generations. Just a good guy all around.
Yeah.
I texted him when I was up on the Hill a few weeks ago and he said, okay, I'll be in my office at this time. Come by. And we talked for 20 minutes. And he actually stepped out of a session to shake my hand and say, thanks for driving up from St. George.
Yeah.
I mean, just a good guy. And we get that chance locally to do that.
Yeah. And you were up on the Hill so much, man. There's so much gratitude to everyone on the board and all of the community coming together as PT. There's so much effort that it takes to make this happen. There's so many steps to bills. There's so much energy, so much collaboration. And sometimes it feels like a little bit of a fire hose. But what I love about it is everyone's in it.
Yeah.
It's like, let's do this together. Whatever we can give, let's give, right? And sometimes one of us might be pulled away in life circumstance where we can't respond, but others jump in to help, and then vice versa. And it's just like, whatever you can give it, and we'll do it collectively as a group, which ends up being enough when we all work together.
And that's the best part is it's a group. You don't feel like you have to be the one doing everything. Mm-hmm. There are so many people willing to step in. I mean, we keep adding to that group text because more people want to be involved and want to help where they can. And they may only be able to give a few minutes or do a little bit of research and find a couple articles that we can use. But when you have a big group of people that are willing to do that, 10, 12, 15 people, I think that's what the group size is now.
Absolutely.
And it makes it so nice to have that, to know that you have a whole group behind you. Because I'm in St. George. It's a 4.5, 5 hour drive, depending on the time of day. It could be 6 hours to get up on the Hill. So I don't have that opportunity a lot. But I know you've put in a ton of time up there, and a lot of other people have. And that's what it takes to get a bill through, is you've got to spend the time shaking the hands and educating the legislators.
Yeah.
I think if they have the right information, they will make the right decisions.
Yeah. Yeah, I love that. Anything else as we wrap up this podcast that you hope that society, PTs, whoever's listening this knows about the future of healthcare?
I think the future of healthcare is brighter than it ever has been. If you listen to the news, you wouldn't think so.
Yeah.
But being on the education side and being in clinical practice, I'm at 26 years of practice now. And it just blows my mind how much better we're getting at doing things. The technology that we're able to use in healthcare now, the amount of information that we can get so quickly. We're improving education. Everything about healthcare is improving.
Mm-hmm.
What we're going to be able to do in 5 years is, to me, is incredibly exciting, because 5 years ago, I thought the same thing, and now we're there. In 5 more years or 10 more years, as fast as technology is changing, Star Trek's not that far off.
Yeah. And the way that we started the podcast, we talked about how there's more people leaving the profession than there ever has been, right?
Right.
I'm right there with you. That's why I started this podcast called The Healthcare Revolution, because I believe the future is bright. I believe that healthcare is and is going to be the best it's ever been. We have the most technology. We have the smartest people. We have the most well-educated people. We have people willing to stand up the hill and make changes, right? We have now physical therapy on the front lines that can add so much value to prevention before these things get crazy, and opioids and injections and surgery, right? When they shouldn't be. We're matching tools to customize treatments for our patients, right? There's just so much goodness in healthcare today, and I'm so excited for where it's going.
I really am. I think it's amazing what we're able to do today compared to 10, 20 years ago, and it is getting better all the time. We tend to watch the news too much, I think, in today's world, and rely on it too much, because one of the reasons I've been so active through my career, I wasn't early on, and I luckily had a friend push me into it, really because she got sick of me bugging her, because she was on the board at the time, and I kept saying, why are we doing this? Why are we doing this? You've got to push the board this direction. She finally said, why don't you run for the board and you do it? And
Smart.
and so I did the next year. I actually got beat that year, but it started the advocacy side for me, and I've been doing this for a long time. And a lot of it's because the people that I meet and I interact with motivate me. They're brilliant. Some of the smartest people, I just didn't know people were that brilliant with things. And everybody has a different area that they take on, and that's where their brilliance is.
Absolutely.
And it makes it so much fun to be around that it pushes you to be better.
It really does. Yeah, I love that.
And so, that's one of the reasons I love where healthcare is going, is the people that are in healthcare, they're incredibly smart.
They are.
It's fun to be around.
And so passionate about making change and improvement, right?
Yeah.
And that's what is so fun, to be around people that just want to improve. And we started the podcast that way too. Like, let's focus on progression. Let's focus on making things better, getting to the next best thing, not getting stuck in our old ways. So love what you've brought to the podcast. Love what you're doing for the community. Thank you so much for all the years that you've already dedicated. I think you got at least 20, 30 more to go. And at least I hope you do, because I've enjoyed rubbing shoulders with you and learning from you. It's been a pleasure. So thanks for being on the podcast.
Thank you for the invitation. I've been watching it for a long time, and you do an awesome job with this. I think it's fantastic.
Thanks, Drew. Appreciate you.